Dr. Keilman's an assistant professor and nurse practitioner at the MSU College of Nursing. She received her BA at Concordia Teachers College, her degree in nursing at Lansing Community College, her master's in nursing at the College of Nursing at MSU with an emphasis on gerontology, her doctorate of nursing practice at Oakland University. She's worked as a nurse at Lansing General Hospital in multiple departments. She's taught nursing at LCC. She served as a visiting lecturer at multiple educational institutions, and she's a content expert at the Geriatric Education Center of Michigan, which is one of our grant partners. She is a nurse practitioner currently at the Ingham County facility on Dobie Road, and she has been extremely active in our grant program, and we are so grateful to have her. So please welcome Dr. Keilman.
Thank you, Dr. Monson.
Oh, you get to get that, too.
I don't need it.
Okay. Well, for the recording.
Good morning, everybody. Can you hear me? I am very happy to be here today, and one of the things that I love is the principles of osteopathic medicine, and that is why I got involved in this new development of a geriatric fellowship between family medicine and internal medicine. So this is a quote from one of my geriatrician friends, John Morley, who's at St. Louis University Medical School. And really, when you are taking care of older adults, we're really helping them through life's journey. And they've already lived a lot longer than we have. They have incredible experiences that we can't even relate to, because so much technology and changes have occurred in the world. But I like to talk about it as being a guide on the side and not a sage on the stage, because we're not telling them what to do. We should be working with them in a mutual partnership and empowering them to make the decisions that are most appropriate for them. Back in 1998, Rowe and Kahn were individuals that first tried to look at how do people age and what can we say about aging. And the thing that they came up with, that you've probably heard a lot about, is successful aging. If you look at this diagram, what you'll see is really what people need to do is avoid disease and disability, maintain high cognitive and physical function, and then engage with life. And you can see how those circles come together. If you do those three things, then we can say that you successfully aged. Now, think about older patients that you've taken care of, or even friends or family that you have in your own life. Is this possible? Can we actually avoid disease and disability? Who here is going to do orthopedics? Anybody? Nobody's going to do ortho? I know, but like, are you going to specialize though? Like in arthritis, or, you know, you kind of are, aren't you? Because what is about arthritis? When do we start seeing arthritis? When? About age 40, actually. And it depends on what your lifestyle has been, because there can be a lot of wear and tear, whether symptoms are bothersome or not. Depends on the individual. So we have that. Plus normal aging. Were you taught normal aging in any of your classes? What are the normal aging changes that occur? You should know them because they make a huge impact on symptoms that are sometimes treated, that are normal aging, that are diagnosed as diseases. This is a huge problem, because if you don't understand what normal aging is, then you think there's something wrong with the person. So we age normally. All of us are aging. And so it's important to understand what is normal so that then we are able to tell deviation from normal. Optimal aging is really, as Dr. Monson pointed out, the foundation of what we should be doing when we're working with older adults. And I'm going to explain that concept to you. Ken Brummel-Smith is actually an MD who came up with this concept back in 2007. He's at the University of Florida. He was a colleague of Dr. Kamara's. But really, the definition of optimal aging is a capacity to function across many domains: physical, functional, cognitive, emotional, social, and spiritual, to one's individual satisfaction and in spite of one's medical conditions. So really, what that is saying is that older people, and the older they get, the more illnesses we see, the more comorbid illnesses we see. And how is it that we're going to help those people to learn to live with diabetes, coronary artery disease, arthritis, all those things that we see as people get older? It's about adaptation and the ability to live the best that you can. It's about plasticity. What do you think plasticity is? When we apply that to a human being, what do you think that means? The ability to learn, that's a great thought. What else? Plastic. It's moldable. It can change. So that's a concept that we look at when we are taking care of older adults. And it also takes into account the person's environment, not only in their home, in their neighborhood, in their community, but the global world as well. And those of you who have interest in culture or who actually are from different countries recognize that everybody is not the same from every place in the world. And that's why culture is extremely important to understand about individuals. And then also resiliency. Resiliency is really a process. You could say that through medical school you've had to become resilient because it's a lot different than undergrad. And you get to medical school and it becomes your life really. But how do you still live your life? And how do you still have quality? You become resilient and you figure it out. Well, this is a concept and a process that should be applied to the older adults that we work with. And what about optimizing performance? All the pictures in these slides are of actual centenarians, or individuals who are 100 and older, except for a few, and I'll point those out to you. But she smoked since she was 7. Gosh, shouldn't she have developed cancer? Or some type of respiratory disease? She doesn't. So what is it about her? What is it about the people that never smoked and didn't live in environments where there was smoke or pollution and they do develop cancer? So it's about looking at things with different eyes. Now here are some of the older people. Luella is 92. She actually takes place in the Senior Olympics, which they have. She actually does a lot of swimming. She beats younger people. So the U.S. Centenarian Club is made up of mostly women. That's not surprising. We know that women generally live longer than men. This information is from the 2010 census. There's about 54,000 Americans who are 100 or older. They're found mostly in California, New York, and Florida. That kind of makes sense. But the states that have the greatest number of individuals, 100 and older, are North and South Dakota. We're going to talk about that a little bit more. I'm working with faculty in journalism and communication arts. We're applying for grants to study the stories of centenarians, which need to be recorded. If anybody knows anybody in the state of Michigan that's 100 and older, please give me their name today. But we're looking at determinants of health. What are those factors that contribute to how each of us ages? And it's personal, it's environmental, it's financial, and it's also about the healthcare system in which people have to get their care. So let's talk about what we're thinking about in relationship to determinants of care. Certainly function. Function is the most important thing. People will say to you, and perhaps you've heard this, I don't want to live to be old if somebody else has to take care of me. Disease. We know the older a person gets, with normal aging and the changes that occur with normal aging, they're more susceptible because of some of the changes, particularly in the immune system, for contracting specific disease states. And so how do we help them to live every day to the best? And then what's their social environment and support system like? We know that the more engaged people are with others, the better off they are. And some other things. And the healthcare system, I keep putting that in there. And that's about us who take care of these people. That's how we meet them. That's how we learn about them. They come to see us to seek care. So let's talk about some of the factors that contribute to healthy, optimal aging. And you have a handout which lists a lot of things, which I hope you will look at because I think it's important. One of the most important things is certainly biological factors. Who are we by virtue of who we were born to? And then how is it that we can manipulate or maintain some of those biological characteristics that occur? And certainly we know that exercise and nutrition are extremely important, and I'll talk a little bit more about those later. But avoidance of disease-causing agents. What's the most important disease-causing agent that people can and should avoid? Correct, tobacco. So that's a really good thing. So that's that whole concept of health promotion and wellness. So probably not putting tobacco in your body is a good thing. And then preventive or preventative medicine, which is about things that we're doing right now. What preventive medicine is going on right now in the communities? Flu shots, exactly. Vaccines, exactly. Very important. And we've already seen cases of the flu in Michigan. So it's important that we understand those things and that we still suggest those to individuals. And then staying mentally alert, staying active, doing different types of things. The brain changes that occur in the brain in normal aging are not about intellectual function. People still have intelligence. Reaction time, learning time is different, and a greater motivation is required of a person in their 80s or 90s to learn something than for younger people, because it's got to do with how is it going to benefit me. When I first took some word classes way back in the day, most of the people that were in my class, because I took it in a community center, were all 65 and older. And they were learning how to use Word. Why? Why were they doing that? What reason might they have? Why do you do it? Why do you go on Facebook? To stay connected. So if we think about global dispersion of individuals, people don't necessarily, families don't live in the same community. How many of you live in the same community as your parents or grandparents? A few. But that's the minority. People travel. How do you stay in touch? When you're older and you're on a fixed income, how do you do that without long distance phone bills and things like that? So they're learning, and they can learn. And then certainly early treatment of diseases and conditions and avoidance of, once again, iatrogenic complications. And where do we see iatrogenic complications? Healthcare, mainly hospitals. So genetics is extremely important. And this is about, and there's so much research going on all the time. Every day there's something new that they've discovered, a new biomarker. I was just talking to one of my colleagues in New York, and they're doing some work there, and they have 218 biomarkers for Alzheimer's dementia at this point in time. So it's very exciting. But just because we found biomarkers, what are we going to do about them? If we don't have a cure for the disease, we have to think about the ethical implications of, do we do tests? Give people information, then what are we going to do? Optimal aging is a way to help them learn to cope therapeutically and adaptively to what they might be experiencing in their future. But genetics, it's important to remember, is about potential risk. Just because you have a specific biomarker doesn't mean you are going to develop that disease. So we need to think about that. So genetics is very important, and it's becoming more and more important all the time. And then we have physical and functional health. And all these factors that I have listed here for you really are associated with how long we live, how well we live, overall health, and then really engagement with life. Because if you're a person that can't get out and about, so maybe you require a cane or a walker, and it's difficult for you to get around places, to go places, then you can be pretty well, but if you stay at home all the time, you're going to be socially isolated, and one of the things that we see and we know that occurs with older adults is depression. Depression is under-recognized, under-diagnosed, and under-treated in older adults. We know that. But if you're a couch potato today, should we expect that all of a sudden when you're 70, 80, 90 that you're going to want to be a joiner? Absolutely not. So knowing the person's story is the most important thing you can do. We would love all of you to go into geriatrics. That would be phenomenal. But whether you do or not, as family physicians, you're going to be seeing older adults. And even if you work in a child, pediatric, more you see pediatrics and more adolescents and young people, they have parents, they have grandparents. So we're still going to be seeing older individuals. So Joseph Bruno swam the Golden Gate Bridge 61 times. Have you ever been to the Golden Gate Bridge? You know how long that is? I don't know off the top of my head, but it's a long way. It's a long car ride. So the last time he did it, he was age 72. That's pretty good. Ada Thomas, at 65, retired, was kind of bored, so she took up jogging. She ran her first marathon at 68. And something that just happened this week, in the New York Marathon, the oldest runner was 86 years old, Joy Johnson. 86. It was her 25th marathon. She ran on Sunday. Monday, she always came to the Today Show. So she was actually on the Today Show, and they've talked to her for all these years. She told her sisters she didn't feel very well. She actually lives in California. Went home, took a nap, and didn't wake up. And when her family found out that she had died, they said, at least she died happy doing what she loved. So that's what optimal aging is about. Does that make sense? So it's not that she died. She died healthy and happy. And that's really what we should be doing with our older patients. This gal deadlifts 245 pounds. What is deadlift? Yeah. Would you like to come and lift me? that'd be the pounds for you. But it's laying there and you pick it up. That's a lot. Okay? So I don't know, we're not going to have a contest, but think about that. It made her happy. It made her happy. And then Eleanor started karate at 78. These are incredible. And these particular pictures are from Dr. Kenneth Brummelsmith. So, people, I know that a lot of you, when you think about geriatrics and older adults, especially the oldest old adult, which is 85 or older, what do you think about them? Are they easy to take care of? What are your thoughts? Because if you have such wonderful, perfect thoughts, and we're like wasting our time today, then all of you should be signing up for a geriatric fellowship. But you don't. So why not? Besides the Medicare and Medicaid thing and money. We understand and respect that that's a big deal. Why aren't you all going to do geriatrics? Who here is thinking about doing geriatrics? Raise your hand. And not Dr. Beckhold. She's our geriatric fellow this year. You'll hear from her. Who's going to do? Oh my gosh, one guy in the back. Anybody else? Dr. Monson, did you see that guy? He's right down there. So that's it. So usually, yes?
See geriatric patients and really enjoy seeing them, but just don't feel like doing the extra work for the fellowship.
The year.
Yeah, and unless you're thinking about being a nursing home director, doing specifically geriatrics, but I think most of us chose family medicine because of the diversity of the patient.
And that's a great point, But what I'm going to tell you is unless you get that geriatric component in your education or you learn from geriatricians, and what we see and what we know and what came out in the Institute of Medicine report in 2001, besides the lack of healthcare professionals in this country, is the lack of knowledge of normal aging, let alone changes that we see with older adults. So part of the grant that Dr. Monson has is teaching medical students about normal and abnormal or deviation from normal aging. So I don't think you've had a lot of that at this, maybe not. Have you? I know Dr. Camaro is out there diligently trying to get knowledge across to you, but it's limited at this point in time. So we want you to really think about looking at older adults in a different way, even if you're just going to see them in your practices, because you will take care of everybody. This is Jack LaLanne. Who was that guy? He was a big exercise person. I had the jumping jack in there because it was named after him. He had the first exercise show on TV ever, started in 1951, lasted for 34 years. Every decade, he lived till 96. He would, on his 70th birthday, he pulled 70 boats with 70 people shackled and handcuffed across a body of water. But everybody said, well, it's genetic. Well, he had a younger brother who also lived to be in his 90s, who drank and smoked and did a lot of that. So Knowing the person's story is very important. Nutrition is extremely important. And what I want to say about that is certainly looking at fruits and vegetables. And you can read about this in your handout if you choose to print it off. But there's the rainbow diet. Who's heard of the rainbow diet? So a number of people. It's one way that some health professionals feel that eating certain foods that are certain colors have specific benefits related to aging in a better way. Something to think about. This is certainly, instead of the food pyramid, the government has done My Plate. Well, Tufts University has one of the best nutrition programs in the country. And it has always had a great propensity for doing things with geriatrics. What they've done is taken the government plate, put things into those sections which would be appropriate for older people, specifically people on fixed incomes, and it's okay to have frozen vegetables. Doesn't have to be fresh. And then what you can see is that fluids is important, and then the whole concept of physical activity. And when we say those words to people, or we say exercise, you know, some people are afraid of that. But we're talking about doing the dishes, vacuuming, normal things that a person does on a regular basis that count towards activity because it's not sitting on the couch. So what about optimal cognitive health? There's a lot of different things that have been thought about, but doing mentally stimulating activities, whether it's reading the paper, engaging in conversations with people, reading, being socially engaged, reducing stress, because we know that stress is traumatic, especially over time to the body, and getting adequate sleep is also extremely very important. So when you talk with your patients, one of the important questions related to sleep is when do you go to bed and when do you get up? And of course, because of nocturia, which becomes normal 1 or 2 times during the evening as people get older, what is not normal is when you ask them, when you get up in the morning, do you feel well rested? They could have been in bed for 14, 15 hours. We can't assume that that's therapeutic for them. So asking the question, do you feel well rested, helps you understand whether sleep is a problem with this person. At the nursing home, we have people that say, I never get any sleep. So then our social workers will do tracking, sleep tracking. And we usually find out they're sleeping an average of 13.5 hours an evening. So something else then is going on if they're not feeling well rested, or if their families don't think that they look well rested. So psychological and social factors are extremely important. One's attitude, a positive attitude, is much better than a negative attitude. Optimism is better than pessimism, no matter what age you are. Your viewpoint of life and being happy and understanding what happiness is and having joy every day. And then just being funny, you know, acting out, having a good time. Being a kid again is sometimes what we say. But it's all important to be engaged with others. And then certainly sexuality, as Dr. Munson mentioned, volunteerism, doing for others. Most older adults want to give back because they feel that they have been enriched by things in their life, And now what they want to do is give back. I work with a lot of senior companions and foster grandparents, and they love what they do. And they do great things for our younger population. And so the concept of religion and spirituality, which are very different concepts, are extremely important. And knowing whether a person goes to church or not is only about their religion. Understanding how their faith or their religion may impact your ability to take care of them is what you should know. Christina Pilchowski is an MD at George Washington University, and she's done incredible things. And one of her questionnaires, or 5 questions to ask about spirituality, is faith. And each word stands, each letter is an acronym for something. So if you're interested, you could look that up. And then being more concerned about others than yourself. Really being connected to not only family, but friends, the community, knowing who it is that lives around you. Some of the best places that I have seen come to the aid of older adults who don't have family members living in their community are faith organizations or groups, the Bridge Club, the pottery group, the quilt making group, the square dancing group, because those are important people that care about one another. How many of you are in rural areas or look forward to doing things in rural areas? That's great. And what we have there is the gatekeepers, the people that deliver the mail or the paper, or if they live on a farm and milking cows, the guys that come and get the milk. They need to be people that you understand and know about in your practice, because you can really rely on them to really help you out when it's the winter or somebody is recovering from an illness. It's a really great thing. Social support, we've talked about that a lot. Giving back, very important. And societal approaches. Health education is extremely important. I know I'm always amazed when we're talking with families that have just admitted someone to the nursing home and they have a diagnosis of any type of dementia, but particularly Alzheimer's dementia. And they haven't been told that Alzheimer's is an end-stage disease. I'm amazed. And that some of them think that because they're on Namenda or Aricept or Exelon, that they're going to get better. This is not okay. So how are we going to do better in helping people understand what's going on? And I think community education is a great way to do this. And if you are fortunate enough to be in an area where there are support groups, arthritis, heart association, cancer foundation, Alzheimer's, a lot of times they have support groups and they have education. So as Dr. Monson said, it's not about reinventing the wheel. It's about knowing what's available where you're at, getting to know them. I tell our nurse practitioner students, especially who are going to be nurse practitioners in small areas, take a goodie basket to the pharmacist in the area, because they're the most important people, because they are the ones who fill the prescriptions. So getting to know them is a good thing, and supporting the person. How many of you know the pharmacist where you're practicing? Fantastic. That's wonderful. I call our geriatric pharmacists quite a bit, just to make sure that when we have people on a lot of medication and many diseases, and they have many allergies, sometimes it's good for another person with expertise to help out. Environmental design is very important. Safe water, clean air. So understanding whatever community you're in, what's the environment like? What might be some of the most common illnesses that we see? And then what do we do about those? And certainly understanding that there's, good and bad furniture. For older adults, it's very hard for them to get out of chairs that don't have arms. Or those really nice cushy couches that you just fall into. I've seen people get on their knees from the cushion in order to be able to stand up because they couldn't stand up any way else. This is a Rysdale chair. Looks like a nice chair, but the cushion actually rises, so it lifts the person. There are whole chairs that sit up, but this is much more convenient. And then height of furniture is very important as well. And what you can see on the, this doesn't work, but is a riser. You can buy those at Target, 4 for $50. So it's not that people have to go out and buy new furniture, but how can we help them to adapt? If you're asking them, how are things going, getting around the house okay, and they say, I can't get off the toilet. Well, there's risers for toilets, and there's arms for toilets. And when you help people to help themselves and empower them, then you're really practicing incredible, optimal aging medicine. So thinking about neighborhoods and all that kind of thing, and I want to talk to you lastly about a strength-based approach. Not looking at problems, but looking at solutions. And I think this is extremely important because if we're thinking optimistically, then we should be thinking about a person's strengths. And what this really emphasizes is a person's self-determination and their inherent strengths where they can live their life in some meaningful way on a regular basis. And a lot of times, we don't think older people can make decisions for themselves. Or if their family member brings them and they're sitting in the office and we talk to the family member. This is what older adults will tell you they really dislike. When they're ignored, like they're not in the room. So how about looking at them and their skills, their knowledge, their talents, their competencies? What is possible in their life? What are their life goals? Because everybody has a goal. And you probably have. I've been a gerontology nurse practitioner for 25 years, but before that I worked in the hospital in the emergency department. And I've seen incredible things where no healthcare professional could understand, how is that person still alive? And then you find out they're waiting for something. Graduation. A great-grandson who's in the military who has to be given leave. One of the geriatricians and I that work out at Dobie Road, where Dr. Kamara also is, had a patient recently, 95, who was at the end of her life, and we were making her as comfortable as possible. And she had a son who lived in Texas. And everybody was saying, how do you think that she hasn't died? And I'm like, I think she's waiting for Carlos to come. Carlos got there, spent quality time with his mother. I wasn't there, but the staff and the family told me about that. And a half hour later, she died peacefully. So this, to me, is the great thing about geriatrics, is knowing the person's story, what is meaningful for them, documenting it so that anybody else who takes care of that person also knows their story, and then doing the best that we can for them. And when we are looking at strength-based, sometimes it's hard. Sometimes it's hard to come up with the strength for some people. But sometimes maybe it's the fact that they have a supportive family, or maybe they have appropriate finances, or they have insurance. we have to really think about it. And thinking about what kind of relationship do you want to have with older adults? And how is it that you want to provide care that makes you happy every morning when you get up? We don't tell older people what to do. We give them information that they need to make the choices that are best from them, and then we mutually set goals. And we need to do short, achievable goals so that they feel accomplished. For example, how many cigarettes are there in a pack of cigarettes? 20. Fantastic. So if we tell somebody in our practice who smokes that you need to quit smoking. So you're smoking 2 packs a day, so I'll see you in a month, and then I only want you to be smoking 1 pack a day. Kind of sets a person up for failure. But if you say to them, you're smoking 40 cigarettes a day, how about do you think that in a month you could be down to 35? Do you think you could do that? That's a small, achievable goal. I've seen great success. In fact, I've had patients, when I worked in internal medicine, that really do great things because they're so excited that they actually can do something and achieve something that it empowers them to make the changes that are good for them. Does that make sense? So mutually agreed goals. And then always thinking about motivation and hope. Hope is to the very end of life. Dr. Karen is going to speak about hospice and palliative care, one of my passions, and something that I used to do with Dr. Kamara and before. But people, when they hear the word hospice, think we've given up hope, because hospice is associated with death. But what we need to remember, and I'm sure what Dr. Karen will talk about, is the fact that hope is not about cure. Hope is about care. Hope is about living every moment to the end the best that you can possibly live it. So for death, it would be surrounded by people you want to be with, no pain, symptoms controlled, peaceful. I'm sure we've all seen horrible deaths, and I hope that you've all seen good deaths, because it really is a gift to be with a person as they transition out of this world into the next. Something to think about. So then, interprofessional geriatric teams. There's a shortfall of geriatricians. You know, there's a shortfall of all healthcare professionals. But 2012, there's a little over 7,000 certified geriatricians in the country. We're going to need 30,000. 30,000. We are getting older and older. Fastest growing population is 85 and older. People don't know how to take care of them. So we need to have 1,200 physicians every year over the next 20 years to meet the targeted need of 1 geriatrician for a panel of 700. In the state of Michigan, there's 285 geriatricians. We need 800 some. This is job security. And then the baby boomers, that's a whole nother talk, but the baby boomers are coming, people. They started turning 65 a couple years ago. There's 74 million of them. Their conditions are different. And certainly their attitudes are different about the kind of care that they expect to receive from healthcare professionals. We're going to see HIV and AIDS more, hepatitis C. CDC in 2011 said people how old need to be tested at least once for hepatitis C. Very good. Why? Because that's a disease that doesn't necessarily have symptoms. But we saw all the liver failure in specific disease group, in demographic groups, and thought, what's going on? So does that make sense? And also, we see a lot of sexually transmitted infections because women 65 and older weren't necessarily taught about that. And when they become widows, they do and are, if they so choose, sexually active. But they think about the fact that, well, I can't become pregnant because I'm postmenopausal. But they don't think about STIs. So something to think about. And then certainly looking at everything, the financial system, the fact that we don't get paid very well to see older adults. And why is that? And slowly but surely the government is adding preventive medicine, but why do we wait until people get so sick they have to go to the hospital? Why aren't we doing proactive things and thinking about optimal aging? So if we do these things, what are the potential outcomes then? Improve continuity of care, quality of care, and the health outcomes. I think that that's what everybody wants. But with lower health care costs, effective collaboration and communication, and certainly interprofessional, respecting and understanding the role of all individuals who take care of people, and then working with one another. Does anybody recognize, well, you probably don't, but this is a Navajo individual who during World War II was a code talker. What was that? There were 450 of them during World War II. They helped to win the war for the United States and the Allies. Why? Does anybody know that story? Fabulous. They spoke on the walkie-talkies and set up the plans and used their Navajo language, which nobody else knew, and gave some other code words to it. And it was so secret that the government never spoke about it until 1968, because they thought if we go to war again, we'll have to call them back up. So they couldn't tell anybody about what they had done. Incredible, incredible individuals. I've been honored to meet several of them. And George Bush actually honored them with medals of honor, which they well deserved. But our World War II veterans, 1,000 die every day. That's why knowing their story is important. And resilience and all those kind of things. Sexuality, even if it is just a towel in front of you, they're thinking about it. But having hope, life satisfaction, maximum function, improved quality of life, and happily and optimally aging. Today is one of my residents' 65th wedding anniversary. Their family, 4 children and lots of grandchildren, are taking them out. She has dementia. She was in a hospice facility for a while. And then, just like the world works, she didn't die. But she still has these underlying medical conditions. MSU College of Nursing came out yesterday and was doing some photographs of me and some of the staff and residents, and I got their permission to take their picture. The husband comes every day. She doesn't recognize him most of the time. She can't carry on a conversation that you understand, but he loves her incredibly deeply. So the photographer was so impressed that he said, you know what, Linda, I'm going to take a picture of just them and we will gift it to them. So we put them next to each other, chair and wheelchair. And they looked at one another, and she looks at him with loving eyes, but she doesn't really know who he is. So the photographer said, "Why don't you give her a kiss on the cheek?" Which he did. And I am telling you that that was one of the most incredible moments that I have ever experienced, because it was like there was this awakening within her. And it was like for one moment, she knew who he was. And a tear slowly rolled down her cheek. This is the great joy of geriatrics. Whether you do a fellowship or whether you take care of these people in your family practices. To have the opportunity to work with individuals who I consider walking history books is truly a blessing and a privilege that I am thankful for every day. I went into gerontology because I had great-grandparents and all my grandparents. And because they all lived on farms, many, many great-aunts and uncles. I still have some who are all in their 90s. And even though they lived in Nebraska, South Dakota, and Illinois, and I lived here in Michigan, we would go every year and visit them. They were incredible people. And as they died, my parents always took us to funerals because death was part of life. And I was so enthralled and felt so supported and loved by these individuals that that's why I did gerontology. And I've never regretted it for 1 minute. So I hope that you will think about geriatrics, or certainly learn more about it when you are out there taking care of the older people in your communities, because you can help them live the best life every day to the last day.